This video is about indirect ophthalmoscopy. This produces an inverted, laterally reversed real image of the fundus. Compared to direct ophthalmoscopy, the image we see is lower magnification, but the field of view is much greater. We can also see much more of the peripheral retina. Because the process is binocular, we see a 3D stereoscopic image. This allows us to see depth in things like the cup. Indirect ophthalmoscopy is much better to use on patients with media opacities compared to direct ophthalmoscopy, and because of the longer working distance, it can be much more appropriate for some patients, for example, children. Indirect ophthalmoscopy is indicated when you need to see into the periphery, get a better idea of depth, or for some co-management schemes. Specific indications include flashes and floaters, diabetic retinopathy, ocular tumours, swelling and cupping of the optic nerve head, high myopia, glaucoma, and age-related macular degeneration. With this procedure, hygiene is important to reduce the risk of iatrogenic infection. Your hands must be washed thoroughly and the headrest must be wiped down with alcohol wipes. Firstly, the patient's pupils must also be dilated. Although this process can be done on undilated patients, this requires experience, so when starting off it is better to dilate your patient. We must remember that there is the potential for dilation to cause angle closure. The anterior chamber angles and IOP should be checked before dilating the patient. The slit lamp should be set up in the usual way. The eyepieces must be focused at 40 mag and the PD should be adjusted to suit the practitioner. Then set the patient up on the slit lamp. The patient's chin should be placed on the chin rest and their forehead should be placed firmly on the headrest. You should make sure that their canthus is in line with the marker and that they are comfortable before you begin. You must now select a Volk lens to use for this procedure. There are 60, 78 and 90 diopter Volk lenses available. The higher the dioptric value of the lens, the lower the mag and the working distance, but the larger the field of view. With the patient set up, we can now begin. The illumination system should be put directly between the eyepieces, and you must instruct the patient to look at your ear. The slit lamp can then be turned on with the illumination on low. A long slit of about 2 mm width should then be focused on the centre of the cornea, so that the light passes directly through the pupil centre. The procedure should be carried out at low magnification, 10 to 15 times. You can now introduce the lens. Hold the lens by the thumb and forefinger at its working distance. This will be around 1 cm from the cornea. You should try to avoid touching the patient's eyelashes. To steady yourself, rest the other fingers on the patient's forehead or the forehead rest of the slit lamp. To get your hand into position, you can rest your elbow on the lens case if needed. Position yourself by looking around the side of the slit lamp and make sure that the light is passing through the lens. When you are in position, look down the eyepieces and slowly pull the slit lamp back by around 2 inches. You should start to see the optic disc coming into focus. It should look something like this. To view different areas of the retina, you will need to ask the patient to move their eyes and tilt the lens. For example, if you want to view the superior retina, get the patient to look upwards and tilt the top of the lens towards you. To view the nasal or temporal retina, ask the patient to look in the direction of the part of the retina you are trying to view. You should rotate the microscope and the illumination system in the opposite direction to this. Reflections can be reduced slightly by tilting the lens or by putting the illumination slightly out of click. Because the image is inverted and laterally reversed, you must be especially careful in recording your findings. An easy way to do this is to rotate your paper through 180 degrees and draw exactly what you see. Next we will have a look at headset binocular indirect ophthalmoscopy. For this procedure, a headset is worn by the practitioner and used in conjunction with a condensing lens to allow them to view the fundus. This allows a large area of the fundus to be viewed all in one go. The brightness control is a rheostat on a separate unit, as shown here. You should warn the patient that the light will be very bright but is not going to damage their eyes in any way. The headset has a few filter options which you can choose from by adjusting as shown here. One of the options is a red-free filter to give better contrast of the vessels. In a similar way, we can also adjust the aperture size. The smallest aperture can be used for undilated pupils, but the largest aperture is best for dilated pupils. The pupillary distance can be adjusted using the sliders shown here. The headband can be adjusted with two knobs, one at the top and one at the back. Once in place, you must ensure that the eyepieces are properly level with the eyes. Firstly, the patient must be dilated. Again, we must remember to check their anterior chamber angles for risk of closure. Routine headset bio is done seated, although it is ideal to have the patient laying down. Adjust the height of the patient's chair as appropriate, assuring that you are at eye level. The illumination of the headset should be turned down to around a third using the rheostat. The beam should be directed into the patient's eye. You can then introduce the condensing lens. This should be held between the thumb and forefinger with the side with the white ring facing away from you. Hold the lens at arm's length and around 2 cm from the patient's eye. You should first see a magnified erect image of the front of the eye. You can then slowly pull back the lens until you see an image of the fundus that fills the lens. After some practice, you should ideally start by looking at the periphery and save the posterior pole until the end of the examination to avoid patient discomfort. To look at different parts of the retina, you must ask the patient to look in the direction of the area that you are trying to view and move your whole body to allow you to align the headset illumination and the lens. Again, when recording your findings, you must remember that the image is inverted and laterally reversed. You may initially experience some difficulties with this technique. Common problems include blurred vision. This may be due to being too close to the patient or because your distance vision is not corrected. Double vision. Vertical double vision may be due to tilting of the head or instrument or due to decompensated vertical phoria. Horizontal double vision may be due to incorrect PD adjustment of the instrument, being too close to the patient, or a decompensated horizontal phoria. Reflections. These can be minimised by turning all the room illumination off, keeping the lens as clean as possible, and by slightly tilting the condensing lens.